Tracy Miller, Mid-Valley Clinic.
Molly Morris, Cooley Medical Center.
Wendy, this is Roger Charfier from CSI.
Hello. Anyone else on the phone that we haven't heard from?
Hi, Nicole Van Borculo.
Nicole Van Berkelo, I heard.
So Nicole and who else?
Don Ross from Parkview Medical Group.
One more time, and one of I don't know which one to say.
Maybe it's Shoshana.
Was it Shoshana?
Yeah, this is Shoshana Palmentier at Cooley Medical Center.
And who was the other person?
Don Ross from Parkview Medical Group.
Thank you. All right. Let's go around the room. Start with Gail. I know.
Gail Goodwin Grant Integrated Services. Left to right, Wendy.
Michael Lopez, Grant Integrated Services.
Tessa Timmons, Confluence Health.
Holly Zavanek, Children's Home Society.
Kate Haugen, AmeriGroup.
Dave Coldy, Confluence.
Christopher Lanu, Catholic Charities.
Caroline Tillier, North Central ACH.
Wendy Bresney, North Central ACH.
Linda Parlett, North Central ACH.
Melody White, Family Health Centers.
Karen Jacobson, Family Health Centers.
Deb Miller, Action Health Partners.
Blake Edwards, Columbia Valley Community Health. Kim Fricky with Moses Lake Community Health Center.
Laura Lee, Molina Healthcare.
Vicki Evans, Molina Healthcare.
You guys are faster than my pen.
Shirley Wilbur, Catholic Charity. Pretty Word, AmeriGroup.
Oregon Conference.
And then over here.
John Chapman, North Central ACH.
Sahara Duval, North Central ACH.
Andy Gleason, North Central ACH.
All right. Let's get started. Announcements. If you didn't see the email already, the change plan is now open for edits to update that 2019 plan. If you recall, what you had put in there 2018 has been rolled over to the 2019. So all you have to do is go in and edit and update. And that's due December 21st. So if you have any questions or issues with that, just let us know if something comes up. Reporting, we originally had reporting down for December 31st. We've moved that out to January 10th because we haven't seen it from the developers yet. We should be seeing it very soon, but I wanted to make sure that I can see it and then get it out to everyone prior to give you time before the report is due. And I had a little brain because I realized we did not approve the agenda and the minutes. So I will back up.
But you have the minutes this time.
I have the minutes this time, but I forgot. So, does the agenda look okay? Does anyone have any additions or? Can we have a motion to accept the minutes?
Motion.
The agenda?
Motion.
Dr. Coldy motions.
Second.
Gail second. All in favor?
Aye.
All right. We have minutes from both the October and November meetings are in there. You will notice in the November meeting, we did not outline as extensively Roger's discussion. It's there's a lot of discussion back and forth, and it's a little difficult. The audio or the video actually is uploaded to YouTube and on our website if you're interested in that. But you'll notice that in the November minutes. I think October, Teresa did a good job, but we found it was really cumbersome trying to capture what was being said, and we didn't feel like we were truly capturing everything. So we just felt like we just upload that video with the PowerPoint slides and everything. So can I have a motion to approve the minutes?
Motion to approve.
Chris? Second to Melody. All in favor?
Aye.
All opposed? Back to announcements. Sorry about that. Learning activities. I see my typo glaring at me. Empanelment Spring should be Empanelment Sprint. Is starting Friday. We have several organizations signed up. I'm really excited about this one. And I've heard there's a bit of excitement out there for others too. I've heard that there's a range of individuals who've signed up, some who've been doing empanelment, but they've chosen to participate to see what else they can learn or how others are doing it, and to offer advice for those who've never done it before, to the other end of the spectrum who haven't really been doing a lot of, haven't been doing empanelment to the fullest extent. So see, the cardiovascular disease sprint is coming up. We're looking for a few more participants on that one, just to make sure that it's robust. Just so you're aware, we've had who we thought could potentially participate. They have competing priorities, and so we've opened it up to some hospital systems out of the greater Columbia ACH. We felt like if we could get 5, 7, 10 people to participate in this, it'll be a better learning experience. So we are working on that. I have a conversation tomorrow. Once we get individuals signed up that we feel like it will be worth the while, then Roger will set up a phone call for everyone and really decide, depending on who's participating, when's the best day to hold that sprint and what time. And then there's the QI workshop. We have decided we were going to move that to more of an intermediate level. But we've decided that there's a need for more QI basic level. So we're going to try to do another basic one, and we're going to use the QI affinity group to meet the needs for those who need more. We've identified individuals who are ready for the intermediate, and we will be touching base with those individuals to find out exactly what are they wanting, so that that can be covered in the affinity group. And the next affinity group is on December 10th. From 12 to 1, and if you're interested, Kathy, Rhyme, and Christina will both be on the line, and they'll be talking about QI, and they will be relating it to the change plan. So if you have questions regarding QI and your change plan, that would be a good call to listen
Hey,
in.
Wendy, I don't mean to interrupt, but I just wanted to clarify that the December 10th QI affinity group is from 11 to 12.
Thank you.
You bet.
One question on the change plan. So we're still going to submit our 2019 for first quarter by December 21, but report on fourth quarter by January 10. I'm not
correct.
Okay. Right.
Yep. And that you're reporting on what was submitted October 26th.
Okay. And that's the due date now is the 10th instead of the 20th.
Instead, yeah.
Okay.
Yeah. For reporting.
For fourth quarter.
Fourth quarter reporting.
And we'll still report on the 21st for our proposed.
It's two different things.
Right.
So you will submit your change plan on the 21st
For
with
the
2019.
Okay.
Mm-hmm. And what will happen is they will start to build those reports to report out after first quarter.
And then.
Correct. Any other questions? The WSU Mobile Needs Assessment, if you recall, I sent that out. I'm going to quickly go through it because it was a large document. I don't know that many people actually were able to read through it or take a look at it, but I thought it was important to look at because they are actually using this report to base their recommendations on coming in our community. And if you feel like we want them, I've invited them potentially for the January meeting, but I'll let that be your call. The first one is just the population and race Douglas and Okanagan have around 40,000, where Grant has 90,000. Chelan was not included in this. They'll be assessed later on in the year, so that's why you won't see Chelan in this assessment. And we have predominantly white and Hispanics, which we knew, and Okanagan is a little more diverse than Douglas and Grant. The next slide talks about the less than 18-year-olds and over 65s, but in Okanagan and Grant, those numbers weren't necessarily reported. So you can see that Douglas is Okanagan is a fairly older county. Their over 65s are twice the state average, and Grant is a fairly younger county. Education, 75 to 80% have high school degrees, and it looks like 18%, 18% have bachelor's or higher, and that's pretty across all three counties. And the poverty and uninsured rates, you can see the uninsured, the poverty level in Okanagan is greater than that of Douglas and Grant. And that's more in depth in your slide deck if you want to look at it.
Am I reading this right, that there's really only 43 respondents total?
Yes, you are.
So
Hence the reason I'm going through it really quick. I don't hold a whole lot of weight, but
they need to get a strong message. They did not even ask the major groups in these regions about information. This was, I don't think it's in here, but I was going to wait till the end, but
right.
They didn't ask, I'm not even sure they asked the FQHCs. I can't remember who all they saw. But it was like, there's major players, including us. They didn't ask us in Grant County what we do. And it's
right.
like, if they're going to be planning on using my tax dollars based on this survey. Yeah.
Right. And that's why I felt I wanted to bring it to this group and see if you guys want to bring them. Because I felt like if we can have a collective voice to say, what do we want in this region? Dr. Wallace had some strong opinions also on this. So you're right, 5 respondents in Douglas, 29 in Okanagan, and 9 in Grant, the number of respondents. That's how it's rated. I don't give much weight to any of these. So
Yeah,
I'm just
the
showing.
list of who they did actually ask?
They did.
Report, right?
It is in the report, and I will email that report once again, so you'll have it
No,
fresh.
I had it on the original report. I just don't,
Right.
I just don't remember what.
I may have put it on the slide deck. I don't remember if I put it in there. So the recommendations in general for all counties were having cooperative agreements with local healthcare providers. I did email him and ask him why wasn't that a part of the recommendations. He says it's part of the general and they would do that, but he didn't say exactly who they're going to be cooperating or how. Developing EMR and IT capacity, developing telehealth capacity, partner with local community organizations, connecting to mobile medicine services to meet the community need, provide care with no cost to the patient, develop agreements with local providers and payers. These were some of the recommendations that they had for the regional. Continuing, they had dental service and referral networks. Their mobile clinics would include the well child checkups, family planning, immunizations, urgent care, STI screening, mental health, substance abuse screening, diabetic eye exams. So that's about the extent of the services. They want to build capacity to provide pharmacy and PT and OT, nutrition, mental health, healthcare navigation, and social work. And then interpreter services and home visits. Recommendations for Okanagan was increase the access to temporary primary care that could allow for more permanent primary care. Identify and address gaps to the mental and behavioral health services, providing nutrition and self-care education, and dental and vision services. These recommendations were based on those, 24 responses they received, just so you're aware of that. And this is what they took to their board. For Grant County, they want to focus on the rural areas with the large migrant population, such as Mattawa, Quincy, and Royal City. They want to partner with the Housing Authority for the annual Homeless Connect, for reproductive health services, and work with local hospitals and clinics to shore up primary care access. Address the gaps in screening and treatment for mental health conditions, address gaps in screening and treatment for substance use, and partner with existing dental providers to fill gaps in coverage. Douglas County, they want to augment and expand their dental services, support mental health care for pediatric populations, increase availability of bilingual with special conditions for providing culturally competent care, increase access to reproductive health services, and expand access to substance use treatment and counseling. So I did not actually put those in there, Rick. But
Yeah, no, I'm just looking at them right now. Like in Douglas, they did Waterville School District, Joanne Douglas Health District, and Bridgeport Medical Dental Clinic.
Right.
They didn't, there's big school districts, there's CVC does have an office over there, we have an office over there. It's just interesting that
You read with the grant, who they.
yeah, let me get the grant. Yeah, I was trying
Because
to,
I can almost predict who it is from the responses. And, 9 people, that really is a good idea for the county of 92,000 and however, 40,000 square miles or whatever it is.
Grant County Health District, Luke School District, Dr. Barry Bacon at Grand Coulee, Courtney Armstrong with Grand Integrated, Maria Vargas of Department of Health, DSHS. Yeah, none of the FKHCs are not there. The school district's not there. We're not there. Big, Columbia Basin Hospital had somebody.
Yeah.
We didn't do anything in Quincy. We didn't do it really providers-wise. So, yeah.
Thank you.
Yeah.
would you like me to bring him here for our meeting for January? Try to get him January or February?
Yeah.
Work with his schedule? The consensus of the group? Nod your head one way or the other. I don't want to think that silence is consensus. So, all right. I will work on getting him here for I'll work with the schedule, maybe January or February.
And not to say these folks who did respond did do have input.
It's just not representative.
Yeah.
And they haven't, this needs assessment went out and he was still waiting to present it to the board and the board to come back. So by the time he meets with us, he will have met with his board. And that was Dr. Wallace, do you want to respond? I don't want to speak for you.
Yeah, thank you. I think, I shared some concerns that it might not be representative. In what I read for the recommendations for Okanogan County, there wasn't mention of collaborating with local primary care organizations, and I'm glad to hear that's a overarching goal of theirs, but I think that's essential to prevent the, fragmentation in services that could develop if there are, multiple players in and out of the system. I think we're all, I think throughout the region, but especially in Okanogan County, we're, really peaking in the collaborative efforts that we're doing among our hospitals and between different clinic organizations. And I'd like to take the opportunity to invite them to come in and be a part of that, and to see what benefit they could provide to us as we're trying to do more collaborative work throughout the county, and certainly not try and replicate some of the things that we're doing.
Anyone else on the phone have a comment? Anyone else in the room have a comment? Okay. We'll bring them January if we can get them, otherwise February. Okay, moving on to the MTP performance data update from Caroline.
Okay, so you have these slides in your packet in case you're looking at the small screen in the room. So I shared some of the data that we had in October at the October meeting. At that time, the measurement period was for July 2016 to June 2017, and what we're sharing today is updated data based on calendar year 2017. So it's the same measures that you saw before. Some of them are broken out in age bands that weren't shown in the prior data sets. And what we've done in the packet is we've shown you both the performance of our ACH compared to the state. And then the next slide is those same measures, but by county. And then we've stuck the actual county rates in there so that when you see a green or a red dot, you can actually make sense of like how close are counties or how disparate are they. And we've also included, you'll notice that some of the slides are titled Measures Active in 2019, like this one. So under the Medicaid Transformation Project, their performance framework has some measures that are phased in over time. These that are shown on this current slide are the ones that are active in 2019. What that means that in 2019, it is going to grade us, our region, by looking at how we performed on these measures in 2019 compared to 2017. So the data that you're seeing here is our performance in 2017. And then in 2019, they're going to look at it again and see whether we've improved as a region. Any questions on that? Generally, I can move on to the county level data if that is of more interest. But none of the measures, when we changed measurement period, it's a 6-month shift, nothing really changed that much, except for some of the follow-up measures, and I'll get to that in the following slides. But again, what stood out is the antidepressant medication management and the medication management for people with asthma, which is one of the reasons that we looked into that measure collectively and asked you to gather data. Let's try that again. The county level rates are shown here, and I think someone pointed out at the October meeting when we shared this that some of the variations aren't that great, but if we look at the substance use treatment penetration measures later on, you'll see that there's a little bit more going on when we compare county to county. Again, these measures are active in 2019, and we have the substance use disorder treatment penetration measures there. And if you look at the county rates for that, you'll notice that there's some variation going on between the counties. So for example, when we look at Chelan to state, it's 38% for substance use treatment penetration for 12 to 17 years old, and it's 18 for Grant. So that's like a large swing. And there's probably a lot of reasons for that, one of the reasons, again, that we included the Medicaid rates and volume on this slide is to remind ourselves that each region is serving different volumes of Medicaid patients and also may also have different access to resources, which probably impacts the performance on the measures. So the follow-up measures that we've been talking about a little bit collectively at the WPCC are active in 2020. So that doesn't mean we shouldn't already be working on it, but that means that as an ACH, we're only going to be graded on those measures in 2020, and they're going to compare 2020 to 2018. But what you see up on this slide right now is our current performance as of calendar year 2017. And what struck me when I looked at this is I remembered that we selected some of the follow-up measures because it looked like there was room for improvement, like we were below state, and now they all look green. So I reached out to the state to find out what was going on. And they explained that they kind of tweaked some of the measure specifications or fine-tuned them on some of the measures. So that what really happened is that state rate went down. So all of a sudden we look better than the state. So it's not that we markedly improved.
All relative.
So yeah, take all the data with a grain of salt, right? You try to look at what it tells us in the big picture. But I think even though all the green dots here seem to show that we're doing okay, I think it's still worth noting that the follow-up after hospitalization for alcohol and other drug abuse is lot lower percentage than for mental health. So as a whole person care collaborative, why are we doing better follow-up for mental health and alcohol and drug abuse? That's a question we would want to ask ourselves. What's that?
Access.
Right. So what do we do about that? And here are the county level rates. So again, probably access to resources contributing to this. I think I'll leave it at that unless you have questions, but we are going to share this dashboard on a quarterly basis. So all this data comes from the Healthier Washington dashboard that's available online. We just kind of summarized it in a more visual way with the rates so that you could quickly scan things. And our hope is to just get you a new iteration of this every quarter. And for the follow-up measures, I think it's still, even though there's a lot of green dots, I think it's still worth digging into as a whole person care collaborative, especially because it's so implicated in so many of the projects, bidirectional integration and then transitional care and so on. So it's still, just because the dots are green doesn't mean there's not room for improvement. Questions from the group in the room or on the phone about this data? Does anything surprise you? Does anything not make sense? Or does this kind of validate what you already know based on your own data?
Caroline, this is Tracy at Mid-Valley Clinic. And I may be beating a dead horse here because you and I have talked about this before, but you know, it's very difficult for us here in the clinic to look at specific measures here, specifically the medication management for antidepressants, because I can't pull that data manually. And so it's difficult for us here, you know, any of the other reports that I can pull and look at it, you know, I can go to my providers and go, hey, we need to work on this, or keep doing what you're doing. And some of these, I just feel like I'm blind and I don't know how we're doing, so I can't improve or change our workflow. And so that's the biggest problem that I'm having here. And so it would be great if the state could actually give us that data per organization versus ACH level, county level, because I can't do anything with that.
Yeah, that's a very good point, Tracy. And the state will not give us that data, but at the provider level, they've made that very clear. So there's a couple avenues that we're exploring. One is through access to the all-payer claims database, we may be able to generate some of these measures for provider levels, but there's a lot of caveats there. Another conversation we're having with MCOs, and I recently talked to Molina and Laurel, they may be able to produce this data for you where, and Laurel, correct me if I'm wrong, but I think it's for mostly for entities where you have value-based arrangements, and then you could generate this data for them, these measures.
Yeah, I think what we had shared is for our groups who we're already in value-based agreements, and these, it's more so on the physical health side today. Any of the HEDIS measures, which isn't all of these, but many of them, we do have the ability to report it at both the entity and at the service location level. So
that'll help some of you, but not all, and then it'll just be your Molina patients, not all of your patients if you have multiple contracts. But Tracy, the other thing that we've been encouraging providers to think about is to not, when you look at those measures, you're right, some of them are health plan measures that would be hard for you to extract from your own data, but if you think about what the measure is about, what in that measure do you have control over as a primary health clinic, primary care clinic, and what would you measure? Right, so there's elements to the measures, and I know that Richard from Samaritan had reached out once. Oops, I'm gonna wait for that, okay. Richard from Samaritan had reached out once and looked at some of the measures and asked if he could do like elements of the measure, and I think that's absolutely appropriate. We don't expect you all to be able to generate these measures. In fact, we can't either as an ACH, and that's why the Healthcare Authority is generating these for us. But I strongly believe that we shouldn't get hung up on the exact measure specifications, that there are ways to get at the information and the work by looking at other measures and indicators. Back on that, but I've seen you guys do some of that in the change plan through the optional measures. So
yeah. I don't disagree. I have a question about, is there a place we can go to find out more? So the one I'm looking at is the percentage arrested.
Yeah.
And how do they collect that data? Because especially in substance use, it's out there, but it's not something that we typically track.
Yeah. And it's all in their measurement guide, and I can actually send you a link specifically to that measure if you want, just as a shortcut, because it's many pages. But yeah, it's all online. And actually, if you go to the Healthier Washington dashboard and you explore any of those measures, if you click on the measure, it will hyperlink to the measure specification, so you can see how they define that. Yeah. Any other questions?
I had just one question about, do we have, can we easily get to how many people are behind, at least in our red areas?
Yeah, we are going to get a companion data set from the Healthcare Authority, which will have numerators and denominators for each of the measures, and then we'll be able to share some of that data. So that's I'll make sure we incorporate that information in the future iterations.
How to get to that?
I don't know. Wendy's asking if you all know how to get to the dashboard, and we're happy to send a link after the meeting, or if you Google the Healthier Washington dashboard, it should pop up pretty easily at the top of your search list.
Anyone on the phone have any comments? Okay. Well, I guess the business part of it, if you want to call it that, is coming to an end, and we're going to go ahead and turn it over to Roger. He's joined us in person the last couple of meetings, but he's on the line this time. So Roger, I will go ahead and turn it over to you.
All right, let me just do a sound check. Can you hear me okay, Wendy?
We can, thank you.
All right, thank you so much. Let's go to the first slide. Great discussion on the data. We're going to continue that in a little bit, talking about asthma and follow up to discharge. But we'll start with a continuing of dialogue around leadership concepts that we need to keep in mind. After the last meeting, we had a couple of requests for more information on change management strategies and approaches. So that's what we'll focus on today. And hopefully we can move on to talk a little bit more about really how to optimize your teams, your quality improvement teams that are working on various activities, and some insights and lessons around managing the teams and team dynamics. So today we're going to talk about change, and I just want to remind everybody that when we talk about change, we're really talking about change at different levels. One is individual change and how people change as individuals. The second is how do people change in groups. And then the third is about system change and how we change systems in our organizations. So next slide, please. So you'll hear me beat this from over and over again, that the base level is really a need to understand what drives human motivation. And intrinsic motivation is the type of motivation that leads to long-term sustained performance. Frederick Hertzberg did a lot of work in this area and highlighted that with extrinsic motivation is where most of our management tools and techniques have focused on. It's all been about fear, use of punishment, or sometimes public humiliation, incentives, pay for performance, negative incentives, incentive pay, use of slogans and appeal to authority, all of those kind of activities of when some of the tools we've used. And unfortunately, the evidence base is that very few of those tools lead to long-term sustained performance. So in terms of individual change, it all starts with really understanding that piece of intrinsic motivation. And these are sort of the core variables that drive intrinsic motivation we talked about before. A variety of stimuli, ability to control the variables, a sense of meaning, making a difference, feedback, and recognition. This will be important as we connect to some of the change management theories. You'll see how they tie to this intrinsic motivation. Hertzberg also reminded us that there are things that we have to do that aren't inherently motivating, but if you don't do them, they can be demotivating. So nobody celebrates policies and procedures. The new policy and procedure comes out, there's rarely a party for that policy and procedure. But if you don't have any guidance in terms of policies and procedures, you have total chaos in your environment. There are things you can do that are motivating. If you can give people a sense of meaning in the work, or connect them to the meeting, or give them that recognition, or the ability to control the variables, that will lead to that intrinsic motivation. Next slide, please. So with that baseline, when we talk about individuals changing, some of you are intimately familiar with the Prochaska and DiClemente stages of individual change. This actually comes originally, I believe, from the behavioral health field. It was heavily used in a variety of efforts at smoking cessation, trying to change behaviors. It all recognizes that people go through stages of individual change. There are people that are just not ready for the change. I haven't even been thinking about the change, and this is where we're going to connect it to the management theories in a second, and the change approaches of a need to really set the stage and plan on how can you get people from that not considering pre-contemplation stage to where they're all the way to sustained commitment over time, and recognizing that there's likely to be relapses in our behaviors of our new changes. So and being very cognizant of that sequence of changes that we have to move people through. Next slide, please. Many of you have been exposed to team dynamic training and the Tuckman model, and you've heard the terms. We're forming, storming, norming, and performing. This just recognizes that when you put a bunch of individuals into a group setting, there's a dynamic that takes place. And we'll talk about this on our next call, about some of the pathologies of that dynamic. But groups have to evolve. So if any of you are thinking about having put together a team for this initiative, for example, or the CVD sprint, you may have people that are working with each other on a regular basis, but working in a quality improvement project might be a very different model. Or approach, or a way that they're used to working with each other. It may require some additional processing for that team to mature in this new work. Next slide, please. I've spoken before about the Everett Rogers diffusion of innovation and the early adopters. We talked about this on the last call. Keeping in mind that part of that social dynamics, or the ability to take advantage of those early adopters, not spending too much time on the laggards, and really moving the whole curve along to see what we can do to help improve performance of the group. Next slide, please. So with all of that baseline, this is a very busy slide, but this is where I want to spend most of the time. And in this slide, what I did was pull together some of the major change management models that are out currently being promoted in various educational programs, change management models, in the popular literature, in the evidence base. These are the core models that are underpinning this. The first one on the top left is called Lewin's model. And this is a very simple but powerful concept. And as I go through these models, look at the commonalities, look at the themes that transcend all of these models. And I think that's where there are some robust nuggets of where there's opportunities for us to focus our energies and leadership in teeing up change. So the Lewin model suggested that we needed to unfreeze people. Again, think about that Prochaska where I said people are not even contemplating a change. So all of a sudden we're coming and proposing something. They're going to resist. They're going to be frozen. We need to unfreeze their thinking and help move them along in a very different way. There's a famous story that Russell Aikoff, Wharton management professor, used to tell frequently about Bell Labs in 1958. The CEO called an all-hands meeting of everyone in the leadership position to come to a large auditorium. There's several hundred people called to this auditorium, and he told everybody they had to be there at 9 o'clock or they'd be fired. And they all arrived at 9 o'clock, and a big buzz, what's going on, and real large crowd noise. At 9:05, the CEO hadn't showed up. 9:10, they hadn't showed up. 9:15, someone calls the office, and they say, oh, he left an hour ago. He should have been there by now. And they're all getting really tense. And 20 minutes after, all of a sudden the back door opens, and there's the CEO walking down the center aisle of the auditorium with all of the managers quietly sitting in their seat. He walks up to the front of the room, and for a full minute, stands in front of the audience and doesn't say a word. And you could just feel the tension in the room change. Like, oh my God, what's he about to announce? I mean, this is extraordinary. And he slams his hand suddenly on the gavel on the desk, and he says, ladies and gentlemen, a national disaster occurred last night. And he pauses, and then he says, the telephone system in the United States was destroyed. Now everybody's looking, saying, we just used the phone to call this guy. The poor guy's just had a stroke or something. What is the deal with this thing? And he turns to the group and he says, I want you to know that here we are at Bell Labs. We helped invent the telephone. And do you realize in 1958, here we are, we have not made a single change to the telephone system, to telephone, since before, that wasn't thought of before 1900. We've not introduced a single innovation, nothing new that wasn't already thought of in the 1800s. And he said, for the next few hours, I'm going to liberate you to design the ideal phone system of the future. And he put the senior managers to work of designing what are all those attributes. They came up with over 2,000 attributes of what the phone of the future would look like. You might be able to carry your phone with you. You could take a call and bridge it to somebody else. You could put somebody on hold. You could have a voice recording. You could do a telecast through the phone. You could do all the features that we commonly think of today. There are about 200 of those features, original list, that are common to every phone today, and they're still working on the remainder of that list from 1958. So that's a great example of unfreezing. And then he put people to work on some new learning, and he provided some boundaries, he provided some guidance, and then based on that, they went and designed the new phone system. So this is the Lewin change model. What it suggests is that in leadership, as we're introducing change in the organization, we have to plan for it. We sometimes have to create a fire when one doesn't exist. You've heard the term, that burning platform. What's the burning platform that want people to do this? And when there isn't a burning platform, sometimes we have to create one. Or at least we have to connect them to understand why the change is necessary and why there needs to be unfreezing. Kouzes and Posner come out of the world of consulting through, I believe it was Gallup, and they developed a very popular book, The Leadership Challenge. And in this, they suggested that a leadership's role in driving an organization is first to inspire a shared vision, to get everybody on board in a common direction, a common way of doing things with a shared vision. And as part of that, we have to constantly challenge the current process, constantly ask, why do we do it this way? What can we do differently? How can we improve things? This is why we need to do this. Now, you could argue that that's all part of this unfreezing, this notion of getting the staff ready for the change. They go on to say that we have to model the way. We have to model the behaviors that we're asking people to follow themselves. We have to give them the tools and techniques on how to do that. And we have to then enable others to act. We have to empower people to be able to do the new work. And sometimes that has to be formally sanctioned. Sometimes that has to be with additional training and guidance. And lastly, he says that at the end of the day, we have to inspire that shared vision by also encouraging the heart. We can't just present data. We have to connect this to something that people are going to remember. Those emotional stories, that patient that we saved or that family we saved, and how all of these changes are going to benefit them in a better way. John Kotter out of Harvard has a famous model, and you'll see some of these themes starting to repeat. Creating a sense of urgency in the organization, again, that burning platform, that unfreezing. Forming a powerful coalition. This is that Everett Rogers getting those early adopters together who can help drive the change. Create a vision for the change. Help people answer the question, why are we doing this and what's it going to look like? Most people resist change because they are resisting the unforeseen consequences of change. So how are we really driving and creating that vision for change so people can see it, can feel it? Some organizations do simulation laboratories so people can actually experience the new ways of doing things and not just be an abstract concept. Communicating the vision, really getting that vision and getting it all the way down and getting people to do what they call fingerprinting, getting their fingerprints on it, helping to translate that vision to what is for their work. And when we talk about this vision, it's not just a vision statement for the organization, but if we're trying to really improve things for our patients, for our community, how are we capturing that and communicating where people can buy in and want to join the new way? So when we talk about asthma in a few minutes, or when we talk about follow-up on readmissions, it's helping people join into a vision of why do we want to do this, what's the benefit, and what's the power of us all working together on that new vision. You have to remove the obstacles. There are always obstacles. Interesting enough, one of the biggest obstacles in many of our organizations is mid-level management. Mid-level management who often have not been brought in on the vision, have simply had new things slapped on them, and we're very comfortable just managing the old ways, and often sometimes put up those obstacles. As senior leaders, we have to remove those obstacles, not necessarily remove the people, unless we have to, but really helping get them on board, helping them to support the change. Very important to create the short-term wins. And the evidence base of what we're doing is making a difference. It's one of the reasons we want to work on some of these sprints and show how we can really move the dots together to create some wins, and not just have a series of change plans where people don't actually see how they're translating into an impact. We have to build on the changes and move to the next step, and really look at how do we, what are the infrastructure pieces that are necessary to support the change long term. And then anchoring the changes in the culture. What are those reinforcing mechanisms that are going to help build this into the culture, including in our leadership rounds, our leadership meetings, our stories, our town hall meetings, all the ways to reinforce the changes that we're proposing. On the bottom left hand, you see Jeffrey Hyatt's model. Jeffrey Hyatt's out of University of Virginia. He's a change model has become very popular in many arenas, often used in the military currently, Indian Health Service, and many other environments. The ADKAR model you hear, it talks about build the awareness of the need for change, the desire to support and participate in the change. Again, that unfreezing. Then the knowledge on how to change. That's that new learning that Lewin talked about. And then the ability to implement the change. What are the things that we can do to empower people to execute on the changes? And then lastly, reinforce the changes. How do we reinforce it, sustain it? The last model on the bottom right, and then we'll open it up for a little bit of dialogue here. The last one on the bottom is from the Institute for Healthcare Improvement, who, in working with many change processes over the years, we've seen a direction. This is the old IHI model. I'm much more fond of this model than the more current model, but they talk about the need to set again the direction, the mission, vision, and strategy, and help get people. We have to push them along to a certain degree. We also have to pull them along towards this new vision of what we're trying to get to, what we're trying to change. That requires us to, again, do this unfreezing or build the will in the organization. There are things that we can do to build that will and engage the workforce. A lot of this is that direct ability to give them some control, some engagement, some dialogue over what we're trying to get done. If you're going to get people to change, you need to generate ideas. You need to have new learning. This is where the change plans come in, the change packages, the best practices, the evidence base, the tools, the models that people can be given to jumpstart their work and not have to start from de novo. And then lastly, we have to really execute the change. This is where there's a tremendous amount of failure. We haven't failed in launching new projects. Where we fail most often is in the execution of the projects. So you have to really pay attention to what are those core measures that let us know that we're actually making a difference. How will we know we were going to get there? The ability to intervene if we are running into resistance to change or organizational entropy. And then lastly, at the bottom, you'll see it suggests that there needs to be a infrastructure or foundation to be able to support the change. That may require some internal knowledge management, might require data, might require training, might require a lot of things that we need to be thinking about. So the implication of all these change models is that we need to start by recognize that in leadership, we can't just take for granted that we want to make a change and send out an email or a memo and think that people are just going to jump on board and adopt the change. It's going to require some planning. We have to think through, how have we readied the environment for this change? What are we communicating to people about all of this work in the Accountable Community for Health, all these change plans that we're working on? The change plans developed by one person in a corner office on behalf of the organization, but most people are clueless of what's really proposed and how this fits into the other 20 priorities that we're telling them that we want them to work on. Have we provided them with the tools and information to understand and buy in? Have we gotten their input, that unfreezing piece? to help them be able to sustain it. And then how are we communicating the tools and methods and techniques to be able to do this new work? How are we packaging this to make it most useful and easy for them to understand in their world? And then lastly, what are we doing to really plan for sustainability and spread of the changes that we're trying to make? We talked about spread in a prior call, but how are we really planning for that and being systematic? So let's see what discussion this raises, what ideas, what questions, what challenges are people dealing with when you think about these change concepts. Questions, comments? Have I been on mute the last 15 minutes or so?
We hear you, Roger. Anyone in the room?
Any themes that are common to the models that you heard? What stands out to you? How are you unfreezing your organizations, your staff? How are you preparing them for all of this work that we're asking them to do with the change plans?
Well, I'll take a stab at it since everyone is leaving a pregnant pause. This is Richard at Samaritan. You know, I have a question about the freezing versus maybe change. How do you address the multitude of changes that are coming at organizations? Are we frozen or are we overloaded? I mean, can you get into that paralysis of too many challenges? And maybe it isn't a resistance to change, but more of a desire to have something to hang on to, you know, whether it's a need to prioritize or just deal with the volume and the time that we have to work on these.
I think it's an excellent comment and observation and question. So yes, we are all living in overloaded times. And one of the things we don't do well as leaders is remove work. We add work. And then we're often surprised that we have so many competing priorities. So one technique that's very helpful is if you can find something that you can, I think I mentioned this on the last call, commit euthanasia, kill something, kill a project that has been longstanding, isn't making progress, is not making a difference, just stop and make sure that's visibly communicated. Are there things that people are doing now in current work that you could get rid of? You can ask your staff, are there things that you think you're doing today that are non-value added? Can we get rid of 15 to 20% of our work currently that's not value added? What would you recommend? And by simply putting people through that process and challenging what we do, you'll find that there are lots of things that people can get rid of. It also helps crystallize the priorities. And that's another thing that we can do is to be judicious in the new things that we're plopping on people and organize them a little bit differently. Perhaps we need to spread the work to more people across the board, engaging our staff more. For those of you in a hospital environment, a hospital I worked with realized that the night shift is an untapped resource. They could be working on quality projects from 2 to 4 in the morning. Instead of reading a book and trying to stay alert. That's an untapped resource. The people have never been talked to before about engaging and improving the organization. When I held a call on a night shift at 2 in the morning with the staff and asked them for ideas, they were one, overflowing with ideas, and 2, overwhelmed that leadership had actually asked about their input in making a difference. So if you can find ways to engage people, deploy the work across a broader group, remove work where it's unnecessary and not adding value, and help prioritize where possible to minimize the burden or impact on the staff. I don't know if that helps at all. Other thoughts, other comments, other observations? Any examples of preparing the staff, unfreezing? How are you communicating back all of the work that you're here at the table, spending your valuable time in terms of the accountable community? And it's a rare opportunity you all have to work together to actually transform the health of the community. How's that being captured back to the frontline staff person in the clinic or in the hospital? That nursing ward person or that medical assistant in the clinic, to get them to share that vision, to see the need for the change. What any best practice examples from any of you?
So we have something called accountability wall. So as things are spread, every Thursday it's a half hour long, and it's all about process improvement and sharing what you've done. So we do that every Thursday. Senior leadership is there. They hear the project and they critique or give feedback. Everything we do is trying to remove waste, whether it's time, effort, process, action.
Great example. So you're showing them examples of what people are working on. You're helping to clarify for them the strategic importance, helping to get their input. Again, the ability to control to a certain degree how that's being rolled out. Some organizations create a war room and they have their key data and metrics in there so people can come in anytime and see that. Sometimes they use those as the coffee rooms or the break rooms where people can go in and see the performance of the organization, what are the key strategic priorities that we're focusing on, and how do those connect to these improvement projects where we're putting people to work on asthma or CVD or motivational interviewing or whatever it may be. Other strategies. Bill Arnold was formerly CEO that used to work for Rick Scott, the current ex-governor, I guess, of Florida, when he was at HCA. He was running their flagship hospital, Centennial Hospital in Nashville. And he wrote a book called The Human Touch, and focused a lot on this role of a senior leader in that unfreezing. One of the things he did is he got rid of his office desk and put a round table in it. He moved the coffee pot in administration into his office, and he took off his front door. I'm not suggesting any of these techniques, by the way, as a necessary path, but just as an example. And he would routinely stop staff in the hallway and call their supervisor and ask if he could borrow that staff person for a few minutes. And he brought him up to, he or she up to the office, and there he reviewed the metrics that he felt he was responsible for as a CEO and were the key things that they were reporting to the board. And he asked staff, what ideas they had to how we can move those metrics. How could we improve our Gallup scores for employee engagement? How could we improve our safety for infections? How could we reduce our cycle time in the clinic? How can we do this? And ask staff for ideas and what role do they play or could they play in helping with this? What do you think happened when those staff left his office? What was their reaction? What did they do? Any thoughts? Besides have a heart attack? How do you think they communicated back to their, what did they communicate to their peers?
They share the conversation.
Share the conversation, what the CEO's looking at, that they were asked their opinion on what to do and ideas on how to influence things. He also made sure that before they left, they had an assignment and a project to work on that he could follow up on and get their ideas. So they were charged to go back and talk to their peers for, what are those things that we could remove that aren't adding value, as an example? What can we do to really help free up time, be more patient-centered, be able to make our teams more efficient in their daily work? So these are all, concepts about change. The underlying message as leaders to be thinking about the change, being deliberate in how we're communicating it to the organization, being thoughtful about how we're engaging staff in the execution, those mixed messages that we might be creating, how to reinforce the positive messages, how to connect the dots and those breadcrumb trails, and then what do we need to do to really plan that sustainability and that long-term reinforcement and refreezing of the organization. So let me stop here with this module. I hope for those that requested more on change, hopefully that met the needs. Any questions or comments, feel free to send them offline. I'd be happy to have follow-up and communicate back any answers to questions that may come up. Can we move to the next slide? So any last minute comments or questions on leadership before we, on the change before we move on? All right, let's talk about asthma. As Caroline mentioned, one of the measures that's still persistent is one of the asthma measures. We asked you at the last meeting to see if you could go back and gather some data. We've heard from quite a few of you that the data's on the way, but wasn't quite ready for today. So maybe we just do a quick check-in with those that have been able to get some data. What insights or learning is coming out of your effort? What are you finding out about your data and your population? And we'll put this on the agenda for the next call as more data come in. So does anybody have any data? And if so, what did the data tell you? What insights came out of your preliminary look-see at your population of patients?
Well, it's Richard at, oh, sorry.
Go ahead.
It's Richard at Samaritan. So we have a 50-bed hospital, and then we also have a clinic. What we found first is that we have to go into 2 different systems to get data for clinic and hospital. So that makes this trying to put together something that says, what do you do as an agency or an entity, a little more challenging. So the first thing we learned is that when we're looking at asthma populations as they go through where they get their care, clinic, emergency room, and hospital, it can be a tricky picture to put together. What I saw was through the emergency room, we had, well, through the hospital itself, we had about 170 encounters year to date. With only 17 admissions, I didn't see any readmissions within 30 days. A lot of outpatient tests and treatments, imaging were part of that. 112 though were ED visits, 65% of it from Moses Lake. So we do, serve a larger area than just the Moses Lake area. We have 10% within 20 miles, another 20%, 21 to 50 miles. Then about 5% that fall off the highway. And kind of see us. So in the clinic, we had 77% of our patients were from the Moses Lake area. A lot more visits there. A report we just looked at was for 18 years and older, so we'll need to look at peds. But most of these folks are less than 65 years old, so they're falling into your MCO population, some private insurance, but not so heavy on the Medicare. So I'd see probably 50% and upwards coming from managed care. That's about all I saw. I didn't, it's hard to get all the elements that Wendy requested to get from our data, from our systems. So it is kind of hard to get at those population health issues through our current data collection capacity. So I don't have too many insights, other than there is some data available, but it really didn't point to me like we have a readmission problem or any care particular that was outstanding. Maybe some opportunity to prevent some ED visits. There are 2 patients in there that repeating in their visits to the emergency department, so they may be using our ED as their primary care, or just more education on how to appropriately use the emergency department. We do have the Pathways Hub for most of those folks now, which is a blessing. So I don't know if I got anything else, Roger.
Okay, that's great. Any questions from the group? Any other data from others? Any other insights at this point? All right, well, let's create a little bit of a breadcrumb trail for you for moving forward. And our aim here is to try to understand the populations that all of you are serving, see if there are particular segments or cohorts that represent opportunities for us to focus on. An example that I've given before would be working with the school systems on engaging kids with asthma and making sure that there are shared care plans, and we're monitoring and surveilling and working with them to prevent those kids from missing school and being admitted to the So our hope would be that in January, February, we'd have a clear sense of what the data in the region are for asthma, and that we could then talk about interventions that be leveraged across the environment to start moving those specific dots that we're falling behind and where you're being held accountable for the state, so that we could develop some interventions as a group that can move the dots in addition to your internal quality improvement efforts working on those specific areas. Any questions on those next steps for asthma? Next slide, please. Just as a quick reminder that for those of you that are in the behavioral health saying, well, asthma may not be as big a deal for us, there's there's some increasingly strong links between anxiety and asthma and its impact on patients and their resultant potential admissions to the emergency room. So one, there are populations within the behavioral health community that do have asthma. Two, the whole field of anxiety management for those populations and sharing what we can with each other may help advance all of the efforts across the board. Next slide, please. So Caroline mentioned that in 2020, I guess it is, you're going to be working on follow-up to discharge. I think all of you know that there is another work group that is focused on managing transitions of care and ER diversions, and this follow-up to discharge really intersects with all of those activities. Next slide, please. So what we'd like to do is hear a little bit about what that other work group is doing, see what the intersect is with all of the efforts that you have underway. And then talk a little bit about, in terms of designing a system, how can we leverage your collective resources to continue to work in these areas, support that other work group, but also in anticipation of meeting the measures in 2020, getting a head start on those activities. And I think you'll see that there are some potential community-wide initiatives that could have an impact. John, I think John Chapman was going to talk a little bit about the other work group. John, can I turn it over to you?
Yeah, so I'll just go through quickly and just give you guys a little bit of an update and see where some of the crossovers may occur associated with the different work groups. So as you guys know, I'm focused on the Transitional Care and Diversion Intervention work group, which is a mix of partners, but really the implementation partners, or when you think of the 17 WPCC partners, we have 7 acute care provider partners through the hospitals, and then we also are working with about 10 different EMS partners. And so the Transitional Care and Diversion Intervention Work Group, think of it as really the acute care provider side of working with transitions out of acute care or diverting from acute care. What they can do as organizations to improve the processes. So WPCC, I understand you guys have components of the change plan associated with it to work on your components of it. This gives acute care providers an opportunity to work on their component of it, and then you have to figure out where that blends together. So the work group is really ensuring that those processes get started, and then as staff, as a work group, how that aligns with the other work groups going on. So like I said, that's our work group as a whole, and our work group is a broad array of people. Unlike, I would say it's a little bit different from the WPCC work group or meeting like today, whereas we have probably more of a mix of community members, community-based organizations on the work group, so it's not just as focused on NCOs and implementation partners. And then the implementation partners are really those hospital and EMS partners. And so we've kind of had a parallel meetings with the work group, and we've also had individual meetings with some of those implementation partners to get input from both sides. Next slide, please. So you can see up here a list of our hospital implementation partners, and these are the individuals focused on transitional care management and ED diversion. And so for the most part, we have, like I said, we have about 8 major hospitals. I said 7, but I meant 8. 8 major hospitals participating in this work. Majority of them are doing both transitional care management practices and ED diversion. We, just as an FYI, we had all partners fill out an application, so we didn't necessarily do the change plan route and identify if they wanted to do a transitional care management strategy or a variety of ED diversion strategies. They submitted that. They went through a review process of scoring, a write-back process to provide additional input. And we are actually in the early stages. We just finished signing the memorandums of understanding for that work, and they're really just in the early stages of getting that kicked off. As a number of you guys can see, obviously, they are people within your organization. So we have a mix of WPCC partners who have been both involved in this work and these applications and the WPCC work, and some of it has been from your hospital counterparts. Next slide, please. What we were talking about in regards to follow-up measures was more around the inpatient follow-up at first, and so I'm just going to cover the transitional care management or transitions out of the inpatient side of the work today. And so what our work group ended up doing is we looked at a variety of transitional care management models, and we presented a few of those, and then we decided that we really wanted to take the one that has been developed here locally by Confluence Health. They adapted it based on research and findings they had, and then we wanted to spread that across the region. So this is just really 5 brief bullets about the model. We also have a homegrown toolkit that we put together based on different documents and that I can share, or we can share out to the WPCC members so you can see what it is. But it's focused on the follow-up phone calls 24 to 48 hours post-discharge from the hospital. Those calls are made by a transitional care nurse. Review symptoms, medication changes, follow-up care is discussed during that telephone call. So really it's looking at, when a patient gets discharged to when they see their follow-up appointment, it's bridging the gap between there to make sure that they didn't leave the acute, they didn't leave the hospital all discombobulated, didn't really understand their instructions, and then, there's this gap before the provider gets to see them. RI makes the TCM call, enters a telephone note into the patient's record. If the patient meets criteria for transitional care management billing, the provider who provides the hospital follow-up appointment with the patient may bill TCM code. So you can see already just on those bullets how this process leaks over into the WPCC work. And those TCM follow-up calls, I would say it's a mix of who's actually what department that nurse is coming out of who makes those calls. Some hospitals have it directly in their inpatient care. Some hospitals have it in an outpatient department, but it's a standalone department. Some people already have this occurring in some form within their primary care or outpatient clinic setting.
John, one. I turned it off so you wouldn't hear my moans and groans all the way through. The criteria, the problem with the models of who's doing the phone calls, because if the phone call is not documented in the outpatient chart, you can't bill. So they've got to make sure that whoever's doing this, and I just don't know if talking to Lori, what's happening in the systems to make sure that if a hospital's making that call, they actually forward that note to the doc, so that doc can have the note in their chart, because that's a huge downfall on this, that people think they can charge because they have the appointment only. So just a clarification, people didn't know that. Yeah.
And it is a mix. So I would say the amount of actual billing that's occurring in regards to the number of transitional care management calls are being made are probably a pretty small percentage across the region. And so that's an area of focus throughout the next year, is to educate and get everyone to learn and share best practices on how that billing can occur.
The custody of that patient's care is also
That's for the follow-up appointment.
Yeah, it depends on the charge level, actually. You can still charge the lower level if you see them after 7 days, but
yeah, digitized.
And we can share, like I said, we put together a more than 5 bullet point document that kind of outlines some of those details based on conversations with Confluence and that. So it includes some of that, and then there's probably still additional documentation out there. But you guys are correct on all that. Any other? I'm free to entertain questions on this slide if there's still questions or comments. All right, next.
I have a question for Dr. Horgan. So we have identified a nurse in our small area, Cascade Medical is much, much smaller, so we just have a single nurse that oversees that. Do you have, and she actually receives a discharge list from Confluence.
Right, so you guys are working in conjunction with us, so we don't make the call. That way you keep it in your charts.
Right, and I would suggest that for everyone, that you have a centralized source or resource that's managing that whole thing, because then you don't have overlap and wasted work.
Yeah, it really is a better phone call from the outpatient side than from the inpatient side, is what it boils down to. Yep.
Yeah, so when you look at kind of partnership opportunities around the TCM model, collecting and reporting on data, obviously, patients getting discharged to the follow-up appointment, so you're seeing data from each side of it, from discharge all the way to follow-up. Just as you guys had said, aligning how follow-up calls are made between agencies in the region to reduce duplicity of work. So that could be within your own agency, a coordination between inpatient and outpatient settings. That can be between partners, as you guys had just stated. So they get discharged from the Confluence Hospital, but they're being seen by Moses Lake Community Health Center, or they're getting discharged from Mid-Valley Hospital and they're being seen by Confluence. So figuring out, how you coordinate some of that. Training both outpatient and inpatient staff on the model, so everyone's aware of how the process works. And incorporate TCM codes workflow into the follow-up visits to ensure proper billing and reimbursement. So as you guys have already, before I even got to the slide, figured out, there's plenty of alignment, and it's going to be what's most advantageous for billing for the organization and what works best for patient flow in regards to who is this going to end up. We have 2 organizations, I can easily say, that are partnering with us that don't have outpatient primary care clinics of their own, and so then that's going to look a little bit different, and some of their motivation of doing this is going to also be a little bit different than those who have a more complete health system. So each organization is going to be a little bit unique. Other opportunities, just to list out there to think about outside of the model, a lot of hospital partners talked about social determinant of health screening at discharge, or in the inpatient setting, or in the ED. And so I think there's always opportunities to, again, when we talk about duplicity or commonality, to make sure that we're all, whether if we're not using the same tool, using the same language, so that that information gets transferred, or that we're sharing that information even, so that sometimes it doesn't have to be done 3 or 4 times throughout the course of this work. And then again, around, I think I had some discussions, or I had seen some emails earlier about discharge planning, discharge notes, and how even some of the current stuff that's occurring with the patient gets incorporated into discharge notes, so that if there's something the hospital should know about the patient, that they're also getting that information. So in a way, almost bi-directional communication back and forth. And I know I focused really on the inpatient side, but to be honest, the ED side was very much similar in regards to those key takeaways of what we were looking for around coordination. I would say the other thing that kind of stood out on the ED side is really educating and ensuring the patient is going to the appropriate facility for care. So even more so looking at those who utilize the ED inappropriately, because A, they just don't know where to go, B, there's no other place to go, and seeing if there can be better plans or better ways to getting them to the appropriate facility versus them just falling in the ED for something like a common cold. And I think that can be a partnership amongst, it doesn't have to be an ED problem, it doesn't have to be a primary care problem, it's a partnership amongst everyone in the community to make sure that those patients are getting to the right place care. And that's the quick rundown of it all.
Questions for John? So let me connect a couple of other dots here of what we just talked about. We have another work group that is doing a deep dive into looking at the transitions of care management and the follow-up. And new models and how they're approaching it. And we have our work of the WPCC, so that there's going to be a lot of overlap, and we need to make sure that we're looking at where the synergies are. So, for example, we have the motivational interviewing coursework that's going on, and those opportunities. Those are prime skills for someone that's doing transitions and care management and making those follow-up calls to the patients and making sure that they're able to coach them on doing the follow-up visits. So that would be a great example. I think I just heard a compelling business case issue of making sure that we have those proper documentation into the charts for optimizing the billing. So how are we really packaging all of that so that the players in the system really understand that, and it's clear, and we have the workflows in place that all of you are not leaving money on the table and you're taking advantage and doing the right thing as part of the work. There's obviously the why in all of this, and in terms of that unfreezing, making the case. We know that follow-up to hospitalization and emergency room visits, that there are adverse events that affect them post-discharge that results in coming back to the hospital. So being able to really engage those patients and get them in. There's quite a few patients can be preventable or ameliorated by that follow-up call and follow-up engagement with their practice. Next slide, please. We also know that those with severe mental illness have a much higher readmission rate. And in our measures, we're unfortunately, that's one of the areas of those that have been in for mental illness or substance or alcohol abuse, where that follow-up is not as strong and really represents an opportunity for us in this particular region. Next slide, please. So with all of that, we've got these workflows, and we have to be thinking through, and then what are the opportunities for interventions that we might work on collectively as a group, and how to support the execution strategies of the work group, but also align it in the environment. So you have patients coming to the ER in the hospital from physician offices, from nursing homes, from urgent care facilities, and from walk-in, and those patients end up getting admitted. For most hospitals, about 50% or more of their patients are coming from the emergency room. So as those patients are in, you have discharge planners, and now also potentially launching your transition care managers. How are we working out those workflows? Are those one and the same people? Are they different people? How coordinated are they? And how are they working with the patient and working with the PCP's office? Some of you are having your electronic health records connected to automatic alert systems, EDI or EDIS, whatever systems are being used that can generate an alert to the physician practice or a follow-up. It appears there's a hole relative to the behavioral health centers that information may or may not be getting to the behavioral health centers. I think we heard at the last call that some of you are starting to work on that. So those all represent opportunities. And then the last slide, please. And the last slide are just examples that we've heard. There's social determinants of health screening beginning. One of the challenges is that we're seeing a lot of social determinants of health screening working in the field. The FQHCs are starting to do that systematically for their patients. That may be done in the ER, may be done again as part of the discharge planner, may be done in the physician practice. How are we aligning all of that information and taking advantage of it and not duplicating work? We heard about the transition care model, the electronic reporting models that could be exploited further. There's home visit approaches following up to the ER. Some of that is working with the EMS system. I think there's been one group in specific, I think, that is looking at having EMS workers go into the home after discharge. So there's the extensivist models that some organizations are using where for the really sick frequent flyers that they're following those patients through the system and into the home and making sure that they're really micromanaged. Telehealth. And then other models like the Coleman Care Transitions, which is a 4-month follow-up model, very structured with checking in with patients. So lots of different interventions that could be brought to bear to help support the work that the other works group's doing, but also move those dots that you've identified as a WPCC. What dialogue does that raise for the group? What comments, questions, observations, sharing?
Well, this is Laurel from Molina. I had a question, and I was looking over it at Deb a bit, because I was wondering if part of our intention is also to leverage the, oh, sorry. Not when we were clicking too long, right? Bottom, thank you. Sorry, Laurel from Molina. And my question was just whether or not part of the vision is to really leverage, I think it is, the CCS platform to maybe help with some of this referral triage and trying to make sure that we're reducing duplication. At least that's part of our hope, and that we'd be able to leverage it for that work. And I didn't know, like even today when John was describing the transition care model, like today if someone is health home eligible, I think there's a transition piece that happens with that as well. So it's just that potential duplication that, that again, I'm hoping that part of the vision is that the platform will help us do this community sharing, but I don't know how real or how close or far that might be.
Yes, that would be my hope as well. I know I was hoping in the transitional care model there was more connection to the health home, like the case managers following up or checking with us on health home eligibility, and we haven't quite seen that yet. Though we've picked up, one of my reports today, I think 69 or more health home clients via the hub referral.
Okay.
You know, so we just need to continue to work, especially with Confluence being the biggest case management group, but we just need to work closer with them. Us being able to have access in the health home program, we do have access to Epic, so we can get in there and see and connect to the case managers and connect our care coordinators. So I think there would be opportunity for us to roll up our sleeves and look at our processes a little more.
So you know
Okay. But you're still, what about the TCM model and connecting with
the transition care team on phone call.
so asking the transition care team then to connect and check and somehow connect with the CCS platform too, so care coordinators are connected with, right?
Yeah, it's just so that there is that visibility, so we don't have multiple people reaching out, kind of the same vision for why the hub for coordination, right?
Right, and part of that is going to be to get the referral partner agreements with the health system so they can look into the CCS system as well, right? To see if those clients are either health home eligible because they would be indicated that way, or in the hub working with clients.
Could you move to the next slide? Because I make a bridging comment. So this next slide is a example of a swim lane diagram by roles in the environment and the stages of the visit. And you can fill in this with specific guidance of who needs to be doing what system are they accessing, what are the steps, what are the activities, what is the role, and who does that. But it's really thinking through the workflows here to get exactly how can we make sure that we're not being overly redundant in capturing information. How are we leveraging information that is captured, and how are we being clear on what we're asking people to do in the system so that we're developing as seamless a system with handoffs as possible. Any thoughts or comments or questions on that?
Yeah, I just think, just to back to, you've got to develop a system to get every hospital doing that then. And that's a complex thing on your part to try and figure out how are they going to interact with you on discharge. I think that's potentially maybe asking a lot of that hospital to figure out how they will do that for your members. But we've got to figure out a seamless approach because these are time-intensive phone calls, the post-discharge calls.
Yeah, I would say there's a lot of different things going on, and we're just talking about TCM, but I also know that outpatient has case management. There's health homes, there's the Pathways Hub. So I think a number of this are just discussions we recognize that we're going to have over the course of the next year, and sometimes it will align and fit really well, and sometimes it won't, and we'll just have to kind of figure that out as the year goes along to see how it works. Yeah. To Confluence, to compliment them, when I saw how you guys were doing some of those internal filters, even between case management PCM model when we visited a couple months ago and some of that work. It was, at least internally, they had a good system to figure out, you know, who was going to where so that the TCM person wasn't making the phone call and then someone else was calling that same patient. So there's possibilities there. It's just where it's going to be useful.
Yeah, it's just complex.
All right, we'll keep this as an agenda item and look at where the synergies and connections are and continue the dialogue as we get to workflows. Wendy, I'll turn it back to you. I think we're almost at the end of our allotted time. Any additional final comments from anyone? All right, Wendy, I'll turn it back to you.
Thanks, Roger. So we will move on to roundtable. And before I do that, for anyone who's on the phone that joined after we did roll call, can you just chat your name and organization so we can make sure you're accounted for? We'll start roll call. I used to do it to my left and right, but I'm going to change that up so then no one will want to sit by me. So I'll start with Blake.
For roundtable.
For roundtable.
Glad to be here. Don't have anything else to add. Thank you.
All right. Easy enough.
This is Kim Fricky with Most Lake Community Health Center. The only thing I have to talk about is that I will no longer be attending these meetings. But Stephanie Dalland, who is on the phone right now, she's she's our QI manager at Most Lake Community Health Center. She will most likely end up taking my place in terms of representing our health center.
All right. Well, we're sorry to lose you. You've been a powerful voice in this whole process.
Okay. No, I think we're good.
Nope, I don't think we have anything to add either.
I'll pass Confluence's comment to the two docs down on the end.
Speaking for us.
I will say
Turn on your
that,
speaker.
Microphone.
The behavior health group that's been doing medical into behavioral health and has really enjoying it. Felt like there's some really good things that they're doing. So.
Cool. That feedback.
Nothing to add.
Anything? Go for it.
This is Melody with Family Health Centers. We're ramping up to include that staff level participation, and we're getting a lot of really positive response back from our staff. We're trying to take subcommittees and kind of giving people bite-sized things that they can be involved with so that they feel like they have their own personal ownership with their little sub-topic. And it has been helping them to understand that everyone is going to be involved with this thing. So if they don't get all of the information for everything, they kind of have their piece of the pie that they're focusing on, and they have that awareness that everyone in the organization is working on the same overall goals. So that's been going really well. It's really been helpful for me with the information that we've been getting regarding the leadership, because it does help kind of bring some insight to the different reasons why we have had some resistance in the past, so that we can address that from a standpoint where they really can hear what we're saying and not just have it be another edict from above that that's what's going to happen and it's one more thing that if you ignore it long enough it'll go away, which has been an issue in the past. So we've been trying to apply some of the knowledge that we're learning here to get the mid-level managers and the staff level excited about this, and we'll be taking more of an in-depth look at the change plan to our medical provider meeting to make sure everyone is on board from the provider standpoint. So lots of good things, I think.
Thank you.
My community partner success that I'm going to share is our blood pressure monitor checkout program through NCRL. We piloted it at the Wenatchee branch, and we've had 12 kits checked out. They're available for 2 weeks at a time, and they have instructions on how to appropriately get blood pressures. It's a partnership with UW Research, and it was part of the 1422 grant that we had last year. So we're looking at 2019 to scale up to all of the NCRL branches. And Sahara will send out a video from the news and a blog about it, but we're excited.
And NCRL is the North Central Regional Library. And is it in all the libraries or just Wenatchee?
Currently just in Wenatchee, but the plan is if we get grant funding, we will scale up to all libraries by the end of 2019.
Great news. Anyone else have any updates that they would like to give? Anyone on the phone? All right, I have two things I'll tell you. We just recently asked all of our Grant County organizations who were the MAT providers at each of their sites and how many patients did they serve, just to get a better understanding. It came from a question from the opioid group. So we started with Grant County, and we found that we need to do it for the entire region. So for those in Chelan, Douglas, and Okanagan County, you'll be getting an email from me with a couple of questions, and we'll map it out and we'll bring it back to this group, because it's really telling that you have a lot of concentrated providers there in Moses Lake, and a couple in Cooley, and one in Mattawa, and the rest of the county is pretty bland. And so we'll ask for the other counties, and we'll just bring it back as a map and have a discussion on it. So the other thing is, we're just to give you an update on the coaching network. We've had several individuals apply for applications. There's a handful of good applicants. We'll start some pre-screening calls, and we hope to do interviews. If we get enough to schedule an interview day before the holidays, we will. Otherwise, we'll do it that first week of January. So I just wanted to give you a quick update on that. And I believe that's all I had from our shop. So if there's nothing else, then I guess we will close it out 5 minutes early. Thank you for everyone for coming.